So, with apologies to those who are still coming into Zoom, I'm going to start away. Welcome to this, our first RSPH Sparks Debates series of webinars. I am delighted that our first webinar is Professor Chris Whitty, speaking on the relationship between the state and public health. There seems to be no more important a question right now for public health as we start to move out of more than a year where the state has intervened in our lives, perhaps more than any other time in modern history, on the basis of public health. But this question will also be central to how the UK responds to the pre-existing inequalities and prevention challenges, which will, of course, sit under Professor Chris Whitty's leadership at the Office for Health Promotion when it is set up later this year. Our understanding of what the state should do to prevent the annual tsunami of avoidable deaths is a key debate now as the new public health arrangement is set up in England. So I'm really delighted that Professor Whitty could make time for us. Given the other and very often immediate demands on his time, we are using a pre-record for this webinar, and so there will not be a Q&A at the end, but this does give us the opportunity for Professor Whitty to speak to us for nearly a full hour. I'm going to run through the introduction to Chris Whitty because, of course, you all know he's our CMO for England and the UK's Chief Medical Advisor and Head of the Public Health Profession. He's Chief Scientific Advisor to the Department of Health and Social Care and so has overall responsibility for research and development, and he's the UK's representative on the Executive Board of the WHO. He still finds time to be a practicing NHS consultant at University College London Hospitals and the Hospitals for Tropical Diseases, and that builds on the work he does he did as an epidemiologist, the research and his work as a doctor in the UK, Africa and Asia. He was the interim government chief scientific advisor from 2017 to 18, including during the Novichok poisoning. And before that, he was the chief scientific advisor at the Department for International Development, which included leading the technical work on the West Africa Ebola outbreak, all of which informs his perspective on public health and the role of the state. And so without further delay, I will hand over to Chris Whitty.
Thank you for inviting me to give this talk. And this is going to be a conversational talk, really, with fellow health professionals. And it's asking a question which I think will happens in all of our professional lives. What is the role of the state in public health? Now, if we look at history of public health here in the UK, and this is true elsewhere, what you see is that the period in the middle of the 19th century, so this is really from kind of about 1840 onwards, there was a real explosion of activity in terms of public health at a local level and at a national level. It was the point when many of the roles that many of you are in were created, and indeed the role that I'm in as Chief Medical Officer was created. It was created in 1855. And the Public Health Medical Society, which was a forerunner to the Royal Society of Public Health, was also formed at almost exactly the same time in 1856. And I put this arrow on this timeline here. And this along here is life expectancy in England. And as you can see, it remained really very stable from the end, well, from about 1600 through to about the 1850s. The life expectancy is about 40 years. Lots of people particularly died in childhood. But then from then on in, it began to improve. Now, it isn't all public health through state or other action that did this by any means. It was economic development and medicine of various sorts. But the growth of public health in the state and the improvements in life expectancy occurred in parallel with one another. And obviously one led to some of the improvements in the other. And if you look at that improvement in mortality, initially, that was a significant improvement in child mortality. And what we have here is the age at which people were likely to die and then we also have different points along time where we go back from the 1850s again all the way through to now. And what's happened over time is, firstly, child mortality went right down. That's as these lines here move up to this situation. So it's really very rare now for people, fortunately, to die in childhood. But then increasingly, for quite a long time, people would continue to die throughout their adult life. But that has increasingly become more and more stereotyped over time. And a lot of that has been as a result of public health interventions, some of which are by the state and some of which are more generally. So like all of you, I'm a really very passionate advocate of the power of public health to improve lives. It wasn't the only thing that drove this, but it was a major part of it. And within this, what we found is that infectious diseases, heart disease and stroke, for example, for infectious diseases were the first to improve. A lot of the public health interventions in the 19th century were really against the major infections, so cholera, typhoid, and so on. Then there was a very major spike in cardiovascular disease, also got on top of by various public health interventions. And then running alongside this, mortality from cancer, now increasingly as a proportion important. And again, public health interventions are beginning to make significant inroads on that. For example, the impact of reductions in smoking. So there has been, over the last 170 years, a really remarkable improvement in the health of the public. What is the role of the state in that? And for all of us, as public health professionals, we're aiming to extend healthy life by preventing or delaying death, disease, ill health, indignity, and disability. And I've illustrated this with these two remarkable people in their 90s, the Queen and Captain Sir Tom Moore. What we all want is for people to live long and fulfilled lives. And individual citizens, medical professionals, which I'm using in the broadest sense, everyone who's involved in healthcare, and the state all have a role. And I've capitalized the state throughout this just to avoid ambiguity. Much of public health, much of what all of us do, does not require the state as an entity to operate, but the state has the capacity to prevent death or ill health in many citizens. And the question is, when should it? And that's what this talk is really about. Now, the reason this is a conversational piece is because everyone listening to this talk will answer that question slightly differently. And how you answer it depends on your discipline, your nation, and your time in history. I'm just illustrating it with these famous health professionals of different sorts. Each one of them would have answered this question slightly differently. I'll just highlight three, two well-known, one rather less so in the UK. Florence Nightingale was incredibly effective as an advocate for greater use of state power to improve the health of the public, both in the UK and indeed internationally. Locke, one of our great philosophers of government, would have had a much more kind of structured approach to what was the role of the state and what wasn't. Locke was also a doctor, and a lot of his thinking really came from that. And then one who may be less known to you, President Banda, who was also a doctor, first president of independent Malawi, had a very distinct view on the role of the state in terms of public health. And this would be true of all of these. So this is just making the point that just because you're a health professional doesn't necessarily mean you'll take an identical view on what the role of the state may be. And we should recognize that political tradition is also important. In very broad terms, there has been a tendency for people on the more left end of the centre ground to be more in favour of state intervention, and on the slightly more towards the right end of the centre ground to be less in favour. But there are many individual exceptions to that. But the political tradition, international tradition, which nation you come from, because different nations have a different conceptualization of the state, and your profession and your time in history all have a role to play. Now, an obvious point to everybody on this talk, but just to make sure we're all in the same place. As everyone knows, conventionally we divide prevention into primary prevention, secondary prevention, and tertiary prevention. And the reason that I think it's worth just reminding ourselves of that for this particular talk and this particular discussion is that when we think about how individual healthcare practitioners, whether they be doctors and nurses in clinical practice or other paramedical staff or people working in wider public health, where they are in the system and will determine which of those they get most involved in. Most people only go to a doctor or to another healthcare professional, a nurse or another healthcare professional, if they or their family are unwell. And when primary care professionals in particular, secondary and tertiary care as well, when they intervene with an individual, they may well be involved, particularly in secondary care. Someone has got a risk factor, it's a known risk factor, and they want to improve it, let's say hypertension or high cholesterol, or where someone has already got a disease state and they want to stop it progressing, and on tertiary prevention as well. All of these, though, are based on individual consent. A doctor, a nurse, or other healthcare professional will talk to the person about themselves or their family and say, this is what I recommend, and here are the pros and cons. And there's a discussion which leads to individual consent for the prevention intervention. Primary prevention, for those who are not unwell, often falls to the state. So the state can intervene on a whole range of different areas with people who are actually currently have no identifiable risk factors, or at least they have not been identified, and where you're operating at a large scale. And this is also true for health protection. But the thing about state interventions on this wide scale is that individual consent is not possible. So the state is having to make a decision based on its own view about what society will tolerate. And this is really the central argument of this talk, which is in democracies, the role of the state must depend on the views of citizens expressed through the elected government. It may be the local government, it may be national government. And it's the job of us as health specialists to lay out the evidence and say what could be done by the state to improve health. And we may well put some strong views of our own about what we think should be, but ultimately our job is technical and the risks of doing something, because interventions have risks, and the risks of not doing something. And then it's the job of the elected politicians, whether national or local, to say what will be done by the state, because individual consent is not possible. So they are in a sense acting as a proxy for society. And this becomes more important the further up the ladder of state intervention you go. So if you start off with the classic ladder of state intervention in public health, supporting science to test possibilities, informing the public of things, engaging on a voluntary basis with industry, you're not really using state powers, and it's perfectly reasonable for us all to do those really without recourse to worry about, does the state have a right to do this or not? The further up you move, into nudge taxes or regulation, and particularly once you move into quite heavy use of state powers, banning things, heavy taxation, or indeed making individual citizens subject to civil or criminal law, you're obviously then using powers which an individual doesn't have, which only the state has, and we have to be confident that, in a sense, society is with us on that, as expressed through political leadership. And I think it is important for us all to be aware of the fact that the tradition that the state should interfere as little as possible in the lives of citizens is a long and honourable one. It goes back centuries, and we need to respect it, even if we don't agree with it on individual cases. It's on the both left and the right in politics. It's not a left-right issue. It's commonly upheld also by people in the law. I've illustrated this with Lord Sumption, who's a very strong proponent of this. A lot of newspaper commentators with varying degrees, I have to say, of consistency. But I think what all of us would what everyone would recognise is that there are some things that only the state can do, and in quite a number of circumstances, I think everyone would agree the state actually should do them. Not only it can do them, but it should do them. Now, the set point of public and parliamentary opinion on what the state should do changes over time. And I'm using a rather extreme example here. I don't wish to draw parallels with current debates, but using an extreme example just to demonstrate this. It was extremely controversial when it was first proposed for the state to prevent children under 10 from being sent up chimneys to clean them. It was widely accepted it causes serious and lifelong health damage. That wasn't a contested point. And it was thought by some in Parliament at that point in time to be an imposition on trade. It was unreasonable to prevent chimney sweeps who employed, for want of a better word, these children from going about as it was seen their lawful business. The campaign to ban this began in the 1760s, and it took over a century before an effective act was passed. And then, if you look back, we look back and we think that's extraordinary. But the fact is, public opinion on this issue shifted very strongly, latterly, particularly because of a very famous novel called The Water Babies. The history of this is an interesting one. But at any particular point in time, for most risks to health, there are broadly three possibilities. The first is that the public overwhelmingly expects the state to act to protect their health and the health of their neighbours and their families, and would be very critical if it did not. Much of what I talk about for the rest of this talk is about those areas, but there are also areas where the public overwhelmingly expects the state not to interfere, and would be very critical if we did. For example, we could say, well, some children are injured by if they go rock climbing, so we should ban rock climbing, or sweets are extremely bad for children's health, and therefore we should ban sweets. At this point in time, I'm confident that the general public will consider that to be state overreach, and I think most people listening to this would agree with that's where the current debate is. And I think most people actually know, without really having to analyse it in too complex a way, where are the areas where they think the state definitely should act, and where does the public think overwhelming the state probably at this point in time should not act. And then there are some areas where the public is split. Some people say the state should act, and some people say the state should not act. One of these ones, political tradition about the role of the state, comes very much into play. Some politicians would say, yes, you should do this, and some say, no, you should not. But for large numbers of areas, it really, I think, in my view, is actually quite controversial, which are the first two you're in. And this is the second central point of my argument today, again, which people listening to this call will take a variety of views on. They don't all have to agree with this. But these are examples where I think that the public expects the state to act, and importantly, has usually done so for generations. If you'd gone back 100 years, people would still have expected the state to act. And I'll expand on several of these examples. The first is where the risk is shared across society. So if my neighbour takes a risk, they're increasing my risk. And good examples of that, which we're seeing at the moment, are epidemics, infectious diseases more widely, including things around vaccination, safe water and safe food, and also non-infectious things like pollution, especially of air and water. These are situations where I can't reduce my risk without reducing the risk to all of society, and only the state really has that capacity. The second group, where I think it's relatively uncontroversial at this point in time, is where there is a major power balance which may kill, maim, or injure people in terms of their long-term health. And in particular, industrial injury and occupational disease, industries which are based on addiction, like smoking, and very dangerous industries like motor vehicles. And in those situations, the public expects the state to act because the state has the power to act and to protect them from, for example, a very powerful employer. And the final group where I think it's uncontroversial is around protecting the most vulnerable. And classically, that's been children and maternal health more widely. So let's give examples of these in a sense to flesh this out. So the first one is where states have intervened to reduce the impact of epidemics following contemporary beliefs as far back as we have records. And really, if you go back in history, you'll see that the state has been expected to act to reduce the risk of an epidemic going back many centuries. So, for example, quarantine laws, 14 days if you've arrived from overseas, for example, go back at least to plague pandemics of the Middle Ages. So what we do now about COVID at borders would be recognisable to people 400 or 500 years ago. The state has often acted very forcefully to detain the sick until they've recovered or died to prevent onward transmission. In fact, considerably more forcefully than we act now. And there have been quite frequently particular bans or regulations of what were perceived to be high-risk close contact professions. Barbers was an example, for example, which was heavily regulated at various points. For example, when there was an epidemic of syphilis in the early modern period in England. So some of the things we do in epidemics are things that have been done for many generations, and the expectation is the state will act by the general public. This became more scientific in the sense that it was based on clear evidence, in particular with John Snow and others in the middle of the 19th century. And this is history which all of you know, the mapping out by Snow, which demonstrated that cholera was associated with contaminated water, and then the things that flowed from that. And much of the history of scientifically based, evidence-based public health really can be traced back to this point in history, when epidemiology, one of the great tools of public health, took place. And that allowed us to be able to say to those wielding state powers, actually, this thing will work. If you do this, then citizens will have a reduction in their mortality and morbidity. And the support for the state to take action in these areas, I think, is pretty clear. And if you just think about the actually quite remarkably strong state measures that have been taken over the last 18 months to combat COVID-19, the data on this in terms of polling numbers, in terms of what people approve of, have been consistent. The general public has been extraordinarily supportive of strong state action as a way of protecting themselves, their families, and wider society. And the initial lockdown measures, which were very strong by the standards of the last many decades, had over 90% in the UK, and actually current measures still have strong support from the general public. So this is a situation, and what people are expecting the state to do is not to protect an individual from themselves. They're protecting all of society by making sure that everybody actually sticks to the rules. This is what the state can do. Because in all epidemics, if I increase my risk, I increase the risk for everyone around me. And most people want to reduce the risk themselves, their family, and vulnerable members of society. This is a very strong altruistic end to this. Lots of people wanted action on COVID, not because they saw a threat to themselves, but because they saw a threat to vulnerable people in society. And they don't want other people to increase the risk to the entire community as kind of as freeloaders, essentially, although the perception of this is often unfair or exaggerated. And interestingly, if you look at the polling again, the great majority of people think that they and their family are going to stick by the rules, but they think everyone else is not going to. And that's one of the things they hope the state will do. Only the state can ensure we all reduce risk. Only the state has the authority and resources to act fast and limit the damage. And whether it's imposing lockdowns, restricted travel, switching research priorities, expanding healthcare, underwriting furlough schemes, it's not obvious what the alternatives to the state are. Either the state acts or no one else really has the capacity to act. So this is a situation where the state, if anyone's going to act, it's going to be the state, and there is overwhelming public support for the state to act. One interesting side effect of that is when people are asked the question a bit about how much responsibility do you think each of the following have for ensuring that people generally stay healthier. If you look in the period prior to the COVID pandemic, and what people have said in 2020, 2 years later, there's been a strong shift towards a view that the NHS and national government and local government have a responsibility to ensure that people generally stay healthier. So I think there's been a realization by people that they do have an expectation that the state will act to protect their health. But of course, COVID is not the only infectious situation where states have had to act. I'm just giving a few examples where the state has been expected to act and indeed has acted effectively. Ebola, AIDS, Zika, SARS, all of these are areas where which happen. And epidemics smaller scale than COVID epidemics happen repeatedly. These are not just one-off events. Something on the scale of COVID really only happens quite rarely, but something that is significant happens much more frequently. So that's epidemics. The state has also been expected, again for centuries, to be responsible for protecting from contagious epidemic diseases. Often in many ways that we would actually see now as state overreach. Leprosy, for example, one of the most extreme examples, sufferers were excluded from society by the state or state proxies, such as the church, and when it was then operating as a sort of parastatal things. So, for example, close to here, where I'm speaking, the Hospital of St Giles in the Fields was founded by Queen Matilda, administered by the City of London until 1299. And this is a place where people who had Hansen's disease, leprosy, were isolated from society, but also supported by society. There was an understanding that there was a kind of quid pro quo. Syphilis, slightly later, led to substantial regulations of trades, and tuberculosis wards and fever hospitals were expected to be provided by the state well in advance of the NHS being available. So the understanding that contagion was something which the state should take action to prevent. And in fact, although there is an assumption by many commentators that the state's use of powers for public health have increased steadily over time, that's not in fact true in this area. Proportionality is obviously essential when using state powers. And if you'd gone back to the 1930s or earlier, the state had extraordinary powers and used them if individuals became unwell in the pre-antibiotic and largely pre-vaccination era. This is a rather sad painting by Lowry of the fever van. Children who had some of the major contagious diseases, scarlet fever, for example, would be removed by law from their parents' houses, isolated. Many of them might die. All their positions would be burned, their wallpaper would be stripped. This is something which you might think now unimaginable, but this is a standard use of public health powers within living memory. So this is an area where actually the state has been able to retreat from its powers because of the advance of medical science, because particularly of improvements in sanitation, in reductions in poverty, better living conditions, vaccination and antibiotics. And the provision of mass vaccination programs are another area where the population has always been incredibly supportive. There's always been some people who have been cautious of that, really right back to Jenner's era. But people often forget what it was like in a pre-vaccine world. But smallpox, polio, diphtheria, various forms of childhood meningitis, these are examples where the individuals are incredibly supportive of, by and large, the state taking powers to provide these. Reducing my neighbour's risk reduces my risk. Everyone wants themselves to be vaccinated. Everyone wants their family to be vaccinated, but everyone also wants all of society being vaccinated. And we're seeing the same in COVID at the moment. High coverage protects absolutely everybody. And this is obviously true globally as well. Provision of clean water is another area, along with regulating waste to reduce infections, sometimes based on a misunderstanding of science, but this is the basic presumption. Again, right back over time, providing clean water by the state. For example, you see here the Pont du Gard in Nîmes in southern France. This is an example of the state providing water. And then the great sewerage projects of the 19th century, essential to the growth of London, Manchester, Birmingham, and the great cities of the world. These are two of the most effective public health interventions, and they're really what have led to reductions in typhoid, cholera, and diarrheal diseases, which really dominated medical practice and public health practice 150 years ago. Here, the state has always been expected to operate in different forms and has had a lot of support for doing so. Getting into a slightly more controversial area is food. The principle that the state should be helping to protect people from foodborne risks is actually also surprisingly long-standing, but can be quite controversial in practice, and much more so than some of the ones I've talked about so far. So medieval cities had regulations to prevent spoiled foods being sold to citizens, but they were perfectly happy for them to be sold to foreigners, for example. Compulsory pasteurization of milk, though, is an example of how this issue has been more tricky for public health, and the role of the state has been more contested on food. So TB in children, tuberculosis in children, brucellosis, and a variety of other infections were really quite common with unpasteurized milk. And when pasteurization was brought in in stages between the 1920s and the 1950s, it actually proved extremely controversial. This is at a point when about 1,600 children a year died from bovine TB, and many more died from or were injured by some of the other infections in milk. But there was a very strong lobby against pasteurization. It was made up by parts of the dairy industry, mainly the parts that actually were the high-end ones, that simply they traded on the fact that their herds were more disease-free. And then the very lowest end, who thought this would increase their costs. So those were the two groups. But also there were those who were philosophically opposed for several reasons, including people who said, and this is a repeated thing we've heard since then, that natural infection was a better way to get immunity than any kind of artificial meddling with it. Of course, natural immunity does give you immunity to some diseases, but a lot of people die along the way. That's always one of the reasons why this argument is weak for many diseases. And a more recent example, one which the older of people watching this will definitely remember, salmonella in eggs is another example showing how tricky it can be. It was a major public health and economic issue. And the true statement by a minister at that time, Edwina Currie, that most of the egg production in this country, sadly, is now affected by salmonella, led to a significant reduction in egg production, mass slaughter of chickens, and the minister had to resign on the basis that she damaged the egg industry. We got around this after initial really quite draconian measures for the poultry industry by vaccination. And that's led to a strong recovery from the industry. Things like landmark eggs, people I think now forget why they're there, but they were as a result of the salmonella epidemic. And this superseded mass slaughter of infected flocks. So this is an example where the state had to act through quite draconian measures, through the mass slaughter, and then the state acted through science to develop the vaccines, and then that has allowed a recovery safely of the industry involved. And that has led to a very substantial reduction in salmonella more widely. It's a great public health triumph. There's an example of the use of state powers, but clearly a rather more controversial one than some of the ones I previously talked about. And the same could be said of BSE, new variant CJD. Government had to act. I think there was general acceptance of that, but the industry involved, the cattle industry, was really badly affected. And there are still questions about the methods that were used to do so. So that's infectious diseases. As I say, I think that's really quite uncontroversial in terms of should the state act or not. There is additionally very broad support for the role of the state in reducing air pollution. And this is right across the political spectrum. And these are newspapers that I put up here, which don't agree on very much in many political areas, but all of them would agree that air pollution is something that we should tackle. And this again goes right back in time. Keeping polluting industries away from habitation has long been seen as a state responsibility. And in the UK, for example, King Edward I banned the use of sea coal in London back in 1272, and that was seen as a public health intervention. The biggest spur to UK action was the Great Smog of 1952, and a combination of cold and atmospheric conditions led to at least 4,000 people dying over 3 days, and it may have been significantly more than that, and led to the Clean Air Acts of 1956, and they've subsequently been extended. And this, in the long run, has led to substantial reductions in cardiovascular and lung disease. And I think some of the improvements in lung and particularly cardiovascular disease, people don't really realize what a large attributable fraction came from these improvements in air quality. Now, in some areas, that's really gone extremely well. Sulfur dioxide, for example, mainly produced by coal, has dropped massively as coal has been phased out and certainly moved away from urban areas where people live. And in fact, although the public narrative wouldn't imply this, the UK has done reasonably well in reducing many of the major air pollutants, but we've gotten to a bit of a plateau with PM 2.5 and PM10 particulate matter. And this is an area where I think the general public would expect the state to act. Now, there will always be pushback from interested bits of society. So the fact that most people in society want the state to act doesn't mean that everybody will, and in particular, industries or bits of society that are badly impacted will take a different view. And I think this is an extreme example, but I think it's an instructive one. Lead in petrol was known to be toxic at high levels for at least 2 millennia. So, you know, right back to the Greeks, that's been accepted. Tetraethyl lead, TEL, was developed by General Motors and added to petrol in the 1920s. And the reason that they chose that was it could be patented, whereas some of the alternative engineering solutions to deal with the problem, which is something called knocking in car engines, couldn't be patented. And right from the beginning, this very remarkable public health scientist, Alice Hamilton, said this was going to be very dangerous. But for 3 decades, the research was dominated, in fact monopolised, by the industry. And they said, no, lead in petrol doesn't really contribute to the lead in the atmosphere. And if it did, it doesn't cause any harm anyway. Well, both of those were untrue. And once independent research came in, it became clear that, firstly, lead was very dangerous, particularly to developing brains in fetuses and children, had an impact on IQ, it may even be linked to crime for reasons we don't fully understand. And secondly, that the great majority of that lead came from petrol. And restrictions began in the 1970s, and over time, things changed. But that was an example where there had to be a really quite big push from public health advocates to persuade the government to take on an industry that was really trying to ensure that this didn't change. But of course, the motoring industry and the petrol industry have both managed to survive fine without lead once engineering measures were found to be able to get around that. And this is an example where engineering, in addition to its contribution to sanitation and hygiene, which everybody is well aware of, has proved highly effective. As regulations have gradually tightened over time, the amount of air pollutions that come from diesel and petrol cars and other vehicles have steadily gone down. And because each step has been manageable by the engineering profession, it's been possible to continue to have cars produced at prices people would pay for them, while steadily improving the air quality. We still have quite a way to go. But if you look on this left-hand side at the reduction in nitrogen oxides in particulate matter over time, this is a great and I think under-recognised triumph of engineering over time. And hopefully tailpipe emissions will in fact eventually cease almost entirely because of a move over to battery and hydrogen-based transport. But we still have a way before that occurs. But so that's an example where using regulation can be important. And let me take another road-based one just to demonstrate the complexity of the way in which state powers interact with public health and what the public expect. And I put these in different colours for different kind of uses of state powers. The first one is car design regulations. So if you get into a car, it is much safer than it would have been without state regulations, because the state has simply said you can't sell a car unless it has got crumple zones, more recently airbags, seat belts actually designed in. So this is an issue of regulation. State regulation has led to much safer cars. If there wasn't that, competition would mean that many of these slightly more expensive interventions people would try and skimp on. The second group of things are things where the state itself provides the safety. So it's not just the regulation, it's road design, lighting and maintenance of roads. This is always seen as important state responsibilities, and all of these help to protect citizens. Then there's a group of things which are around the law. And these are the laws which are largely to protect both an individual, but actually to protect other road users from other individuals. So speed limits, driving tests and licenses, drink driving laws, and MOT tests. In all of those situations, they do protect the person behind the wheel because they've got a safer car. They're not drunk behind the wheel, or not having their concentration impaired by alcohol, and they're driving at a much safer limit than they might otherwise because of the law. But it also protects every other vehicle on the road and everyone crossing the road, every cyclist, every pedestrian. And then you've got the only one of these, which is actually highly controversial, which is compulsory seatbelts. And this is because this was seen as only protecting the person who wore them. So everything else in this list, the general public view was this actually protects someone else, but it also protects me and my family. Compulsory seatbelts, the sense was, well, maybe this only protects the person who's actually, so why should they not make a choice? So this was an extremely controversial issue when it was introduced, although in fact the introduction of compulsory seatbelts has almost certainly been very important in the really remarkable improvement in road safety we've seen over some decades. And no one, I think, would now go back. But at the time, if you look at some of the debates in Parliament, including by people who are highly respected, they were very cautious of this move. So that's a good. So I've talked about epidemics, infections more widely, water and food, and air pollution, and then some of the issues around safety on the roads as different ways that the state can act. There is also clear evidence, I think, that the UK public believes government should reduce the risk of being killed solely due to work by legislation. So if you look back on the last year, for which there are full records, 92 people were killed due to work-related activities. Now that's 92 people too many, but if you compare that to where we were back in the 1970s, certainly where we were back in the 1930s, when hundreds and in longer time, thousands of people were killed simply because of the occupation they had, that has been, that improvement, so that over 80% reduction in mortality since the 1970s, for example, has happened as a result of legislation. And the expectation by the general public that a negligent employer should not be doing things that lead to the fact that their own employees go to work in the morning and never come back because of a work-related accident. Although people say a lot about the health and safety executive and some of the legislation, actually it has had a remarkable impact on the probability that people will actually die as a result of their work activities. So that's work injuries, where the expectation is the state will act. And there's also generally support for action against occupational causes of cancer and other diseases, again, where the only reason you're doing it is because you're going to work and your employer could have prevented this happening. And occupational cancers have varied throughout history as industries rise and fall. Everyone on this call knows this. So, for example, one of the earliest recognized examples is scrotal cancer of chimney sweeps. Some of them go away because the industry goes away, but many of them can be prevented by the industry taking care. It may cost the industry slightly more, but it means they won't kill their employees. And there is an expectation the state will act on this. And maybe now only about 1% of the industrial related cancers are avoidable in practicable ways. The last really big one that's left is asbestos. And the history of asbestos in the UK is a sad one. Really, we should have got on top of this much earlier than we did. But we've now reached the peak point at which people die from asbestos with mesothelioma and lung cancer. And it's increased really up to about 10 years ago. It's now on a downward path, but still at very high levels. And this is almost entirely preventable. Almost all of these are prevented by, would have been prevented by using materials other than asbestos. So I think occupational risks, there is widespread support in public, and it's really relatively uncontroversial. Moving slightly further down the controversy spectrum is where wealthy industry uses addiction for its operating model or harms others. And where either of those are the case and the public thinks they're the case, then there is an expectation the state will act. And in my view, the archetypal one is the cigarette industry. We all know lung cancer is the commonest cause of cancer deaths in the UK. Most people diagnosed today will be dead within a year. Still, it's improving, but slowly. But the great majority of these is because a wealthy industry has pushed a highly addictive product they know will kill many of their customers onto them at an early age. And of course, smoking also causes heart disease, stroke, lung diseases other than cancer, other cancers. The turning point in this argument was when people accepted that firstly, addiction was a large part of this, and that the industry was deliberately using addiction. And secondly, that other people's smoke can kill. So it's not just if I smoke in a pub, it's not that I can only kill myself. I'm also potentially injuring the health of all the people around me, every other pub user, and the people working behind the bar. And I don't think I really need to labour this point to this audience, but that case was central to a widespread political acceptance that something needs to be done about this. And I think the fact that smoking should be something that is discouraged by the state, in some cases with extreme prejudice, is something which I think is now widespread across the political spectrum. It became even more so when it became clear from some of the industry documents that became apparent in particular court cases in the US, in fact, that the cigarette industry was deliberately targeting children. And I'm just going to use, just going to pause for 1 second on these really horrifying quotations. And just, again, to demonstrate that this is an area where the public is behind action, 74% of smokers think that smoking should be banned in cars for children. So this is something where, even if someone is a smoker, and smokers are citizens and have sensible views like anyone else, they very strongly think that children should not be targeted and should not be exposed to smoking. I think it is important in our rhetoric, we're very careful never to blame individual smokers for lung cancer or other diseases. They're up against one of the most powerful and effective industries in the world in rude financial health, sadly. Also, I think uncontroversial provision of services. Mass voluntary screening is an example, cervical cancer screening, bowel cancer screening, breast cancer screening. All of us would support those. In these situations, they're not compulsory. The state is not acting to say you must, but the state is acting strongly to encourage it, does the research behind it, provides the service, encourages people to use it. Support for this is really very strong. The great majority of people have their screening, and this has led to significant reductions in mortality and morbidity. Cervical cancer screening in particular, the evidence base for this is extraordinarily clear, but also for, as I say, for breast and bowel cancer screening as well. So these are all examples where the public expects the state to act, and usually has for generations. Risk shared across society, your risk is my risk, a major power imbalance, protecting the most vulnerable, or provision of mass services. These are really uncontroversial, and uncontroversial in my view in every state in which I've worked, and I've had the fortune to work in quite a few. And this has had, as I said, a huge impact on disease, if you put these collectively together. There are some areas which are much more contested, and the reason you can tell they're contested is different states and different points in history take quite different views to this. So the role of the state in individual treatment, including secondary prevention, varies really quite widely by tradition and politics. And if you look around the world, you see very different models where individual countries will quite passionately hold to a position that this is the right way to do it, but they're very different ways. So the UK tradition is a very strong support for the NHS, state provided, free at the point of delivery, even if actually there is some degree of private provision through general practitioners, for example. General practitioners do most secondary prevention in the UK. Nations have widely varying approaches though. A statement that is extraordinarily uncontroversial in the UK would, for different reasons, be actually quite controversial in, let us say, USA, Switzerland, or China, or indeed Nigeria. So we shouldn't assume that the political settlement that is relatively uncontroversial in one state is uncontroversial in all. And you can see that although there is a correlation broadly between the degree of wealth that's in a society and how much healthcare is provided by the state, there's a large scatter around this, demonstrating that political tradition also and cultural tradition also play quite a role in this question. The area which is much more contested is whether the state should intervene where the health problem depends on an individual's choices. And a lot of this depends on really how the argument is framed and how it is framed fairly. And a good example of this is rising obesity. No doubt it's rising. It is a major threat to health, often driven by heavy and persistent marketing by industry, and importantly, by limited choices. There is a reason why obesity is really heavily linked to deprivation. So I think for most people on this call, it's an uncontroversial statement that actually most people who are living in an obesogenic environment have no choice about that. But there is perception by some that actually people have individual choices about what they eat, and that this makes it a much more difficult area. Childhood obesity is a particular problem with a strong link to deprivation, and I think there is very widespread public support for reducing childhood obesity, again on the principle that the most vulnerable should be protected. There's also an argument that the state, the public, pays for the consequences of this. But the questions around obesity in adults have always been a much harder area, and one where different people will come to, with perfectly good intentions, different answers. And we need to be conscious of that when we're framing our arguments, which is just not assume that everybody agrees with our own position on this, which if we're talking about most of the things I've talked about to date, I think there would be a very, very wide consensus among the UK public. So I think all of us come across this, but I think it becomes particularly acute the further up, as I said at the beginning, we move up the ladder of intervention. The further up you're going, the more you've got to be reasonably confident that, that there will be political support for what we're trying to do. And I'll really finish with an example, which I think is a very good example of the state doing something that was effective, and that was the soft drink sugar levy. That was an example where a relatively small state intervention, a nudge tax essentially, halfway up the ladder intervention, total sales went up. In fact, depends on how you measure the data, but it certainly didn't go down. But total sugar sales went down 35%. And this is in all socioeconomic groups. So everyone benefits. People still drink the thing they want. The prices in the group of ones with the lower sugar stay pretty similar. So there's no discrimination in that. Industry still sells perfectly happily, and yet the public health intervention works well. Here's an example of where there are no obvious losers if you take things over the longer term. So this is a very good middle of the road intervention. But when we're trying to do these interventions, I think it is important to stress the role of evidence for a state public health intervention. And this is a point I can't hammer home to everybody I work with enough. We need to keep three things in balance. And for me, there's always a triangle, a kind of eternal triangle, in terms of how far we can push areas in these more controversial areas where there's contested space. And I think the three things in balance need to be the difficulty of the intervention. Is this unpopular? Is it costly? Does it lead to very significant social change? How long will it take? The size of the health effect and the strength of the evidence. If you've got a very clear, big impact on public health and the evidence base is really strong, then you can actually take on a public argument incredibly effectively and say, look, we've really got to do this because the evidence base is incredibly strong and the health intervention will work really well. And this is where a lot of the interventions on smoking, for example, were on very strong foundations. Despite attempts by the cigarette industry to undermine the evidence was overwhelming. The scale of the problem was huge, and the intervention, although unpopular in the sense of lots of people were smokers when it first started, there was a societal acceptance this was a reasonable thing to do. Strong evidence, big effect. If, however, you're dealing with either a very weak evidence base or the size of the effect of the intervention is going to be actually quite small, it's going to be much harder to persuade people to do really difficult things. They'll still do relatively easy things. It's relatively easy. Let us say you to say, well, you should be going for a walk with your family in the evening on a nice evening. That's not you don't need a very strong evidence base, nor does the effect have to be terribly large to persuade people that that's a reasonable thing to do. But if it's a big change you're expecting, you're going to have a strong evidence base, and you're going to have to be able to demonstrate a reasonably large impact before you'll actually get people reasonably to move. So the evidence base is really critical, and demonstrating size of effect is going to be really tricky. So if I were to sum up where I think we are on these more contested areas, as opposed to the ones I talked about in the first part of this talk, which is the areas where I think the public is, and always has been, really strongly supportive of state action. For those sceptical of the state's right to intervene for wider public health, and they tend to be people who aren't on this call, because most of us are in public health because we really do want action. Pro-intervention, if we're talking about the vulnerable, particularly children, there's strong evidence, there's big effect, we can demonstrate it's cost effective, and then for some people, if it's in the healthy working age population in addition to the more vulnerable groups. The ones which tend to make it more difficult, where there will be a strong counter-argument from people from different political traditions, where it removes existing rights, where it removes pleasures, where it exposes the citizen to the law when previously they weren't exposed to the law, where they might be sued for civil or criminal reasons, where it introduces a barrier to trade, where it's perceived as expanding the role of government, and one of the big worries that people have, not unreasonably, on unintended consequences. And I think all of us should be really honest when we look at a new thing we're trying to do. We need to measure it against these to work out where it's going to sit in terms of social acceptability. It doesn't mean we shouldn't act, but we should think about these and be reasonably thoughtful and respectful of people who come from different traditions whilst still trying to advocate for public health. So I'll finish where I began. The remarkable improvements in health have many causes, but state prevention has played a major role, and the Royal Society for Public Health and its predecessors have been with public health and leading public health all the way through this period, right from this point of extraordinary inflection back in the 1850s, as indeed has the role of CMOs and of many other statutory health officials in local authority and in other bits of government. I'm a very strong believer that the government has an extraordinarily important role to play, but I do think all of us have to think this through philosophically and be respectful of those who take different views and frame our arguments in ways that work alongside them. I hope that sparked off some thoughts and some things to discuss with others. Not everyone will agree with everything I've said. That isn't the point of it. But I thought it was useful to provide a framework to think about some of the issues we need to think about when using the powers of the state, as all of us wish to do, to improve the health of the public. Thank you very much for inviting me.
I am sure, I'm just checking whether I can be heard. I hope I can be heard. I am sure we will all want to send our thank yous to Chris Whitty for that frankly fantastic presentation. I know we will be thinking about his comments on addiction and power imbalance and public support as we continue our work, for example, on gambling. I know chat has been full of people asking about whether this is going to be available. It will be available on our website. Initially, for a very short time, it will be available for our members only, but then we will open it up to everybody. So do tell your colleagues and your friends and your family where you can find it. If you've allowed us to send you information, we will send you a notification when it goes live on the website. This is the first of a series of webinars. So next week we have one driven by the interests of one of our members' special interest groups on water safety. So on the 19th of May, we have one on hospital water systems. On the 2nd of June, we return to the RSPH Sparks Debate series when Lord Patel, our president, will be chairing a webinar, which I'm sure will have a Q&A session on the future of the public health system in England. Apologies we couldn't do Q&A today. As I say, it was to do with Professor Whitty's availability, and I think we would all understand why. So I will close this by saying we will ensure that our thanks and the fantastic feedback we're getting in the chat is sent back to Professor Whitty, and to thank you all for your participation. Do send in any suggestions, any feedback, any comments. We will certainly look through all of them, and I hope to see you at the next RSPH Sparks Debates webinar. Thank you.